Good morning, everyone, and we're really glad to see you here. I'm Dave Schneider, Managing Principal for HMA's Lansing office. And it's my privilege today to introduce Director Hertel. It probably doesn't need much of an introduction. You all know who Director Hertel is. But just so you do understand, she is the Director of the Michigan Department of Health and Human Services. Previously, she was the Senior Chief Deputy for Administration, where she oversaw pretty much everything. I worked at the department when she was in that role. Prior to that, she joined MDCH, some of you probably remember MDCH, in 2013 as the Senior Assistant for Policy and Planning. And in February of 2014, she was appointed Director of Policy and Planning. Prior to coming to the state, she worked as a Senior Advisor for Health Policy in the state State House Republican Policy Office, as a legislative assistant to Representative Caswell. She's also worked as a consultant at Public Sector Consultants. Should have been HMA, sorry. And, as a policy analyst at Blue Cross Blue Shield. So with that, I will turn it over to Director Hertel.
Thanks to whoever started the applause. I'm trying to get my family to do that every time I walk into a room. So I'd like to, first of all, say good morning to everybody that I don't ever get to see anymore. It's so nice to see so many of you here that I've worked with for a while now. And thank you to State of Reform and Health Management Associates for inviting me to join you today. And I am looking forward to taking questions, but first I'd like to provide an update on the work that the department is doing, including our efforts to improve access to behavioral health care, continuing to strengthen our healthcare workforce and addressing social determinants of health, and highlighting some of our work to keep kids safe and how that work spans both health and human services. We still have a lot of work ahead when it comes to strengthening the healthcare workforce, improving access to behavioral health care and coordination of care, and addressing inequities. However, I'm incredibly proud of what our employees and our partners like you helped us accomplish in 2023. We cannot do this work alone, so thank you all for your continued partnership with the state. In addition to our ongoing initiatives and investments nearly 1 year ago, due to the changes at the federal level, we restarted our Medicaid renewal process last June. This has been a massive undertaking, and I'd like to recognize the employees in our state Medicaid office, in our Behavioral and Physical Health and Aging Administration, our Economic Stability Administration, and all the staff in our county offices for all of their hard work and finding solutions to so many challenges along the way. I'd also really like to thank our many partners who've been helping to share information with our beneficiaries, hosting so many community events, and helping people fill out their forms at locations in Grand Rapids and Detroit and other events across the state. Michigan will complete our initial cycle of redeterminations in May. Despite the challenges and the scale of this effort, our state continues to be a leader in supporting Michigan Medicaid beneficiaries, especially in finding innovative ways to make the process easier, increase awareness and education, and help eligible residents retain their coverage. So to highlight just a few of our strategies, we renewed eligibility for people who are receiving SNAP benefits or TANF automatically. We worked with our managed care plans, who I see over there back in the corner hiding, hi everybody, who were working to support their beneficiaries and providing them with renewal forms and helping them to complete those. We've extended the time frame to return paperwork so that we're giving people as much time as possible, and we were allowed by the Centers for Medicare and Medicaid Services to adjust our processes and reinstate more individuals who were eligible but disenrolled just for procedural reasons. So in addition to sending out so many letters to our beneficiaries, we also launched a more comprehensive communication strategy, which included letting people know the changes that were coming in renewals through TV, streaming services, radio, webinars, and our partners like the Michigan Primary Care Association to share information across their networks. We even had ads on gas station TV I don't know if any of you saw those. I did see one of those, and I thought my staff was very clever for making the timing for when I was getting gas. So I was really happy about that. When CMS released their strategies that allowed us to simplify the process and reduce the risk of individuals losing coverage, we also adopted as many of those strategies that were available to us. And as a result, we were able to significantly, 3- to 4-fold per month, increase our passive renewal rate. We were also able to confirm that many of the people who were disenrolled due to procedural reasons were because they had other insurance that was available to them. And for people who were disenrolled and needed assistance identifying other insurance options, we had a great partnership with the Department of Insurance and Financial Service. I see Karen over there, thank you, who's probably sick of talking to everyone in our Medicaid office by now, who were just fantastic in making sure that people were moving over to the marketplace when and if necessary. Our most recently released data was February, and through that month we had renewed Medicaid and Healthy Michigan plan coverage for an additional 142,000 people in February, which brings our total to more than 1.4 million people who were renewed for eligibility in Michigan, which is fantastic and significant. So thank you to all of you. The second project I want to mention briefly, but I can't really talk about, so I'm going to dangle this in front of you, is our Medicaid health plan rebid, which I know everybody has been talking about and waiting for the last year or so, including myself. I am limited, obviously, in what I can say on this, but I think everybody knows that we put that bid out in October as part of our My Healthy Life initiative, and working to strengthen our Medicaid services through our Medicaid health plan contracts. Responses from our bidders were due on January 16th, and the Medicaid health plan contracts that result from this rebid will begin October 1st. So we'll continue to keep everybody posted on our progress, and I anticipate that we'll be able to speak more publicly on this very soon. As many of you know, one of my top priorities is improving access to behavioral health care. And with that, it's also important to make sure that we continue to work together on coordinating care. Everyone deserves access to behavioral health care where and when they need it. Our most recent budgets have included investments in access to behavioral health care, which includes increasing the number of programs based in schools, establishing crisis stabilization units in psychiatric residential treatment facilities to take the pressure off our emergency departments, and expanding our certified community behavioral health clinics, or our CCBHCs. In addition, we're working with partners to improve access to the array of coordinated services for children. We were also able to begin the disbursement of our opioid settlement money. We have been a leader in distributing these funds and ensuring that care, health, and well-being of residents in need. And the National Governors Association recognized our state as a national leader in harm reduction efforts. The department was authorized by the legislature to invest a total of $62.4 million of the initial payments into our opioid remediation efforts. Those settlement funds are helping address opioid use and treatment. These initiatives are currently supporting evidence-based programming to address and reduce harm associated with the opioid crisis, and we have distributed more than 730,000 naloxone kits. We've recorded over 6,600 overdose reversals since the 2020 launch of the Naloxone Direct Portal. 6,600 overdose reversals, and that's significant. Last fiscal year, our opioid settlement dollars funded the distribution of 150,000 additional kits, which resulted in the reversal of about 2,600 overdoses. As part of the effort to get naloxone into the hands of our community partners, the Youth Connection in Detroit has provided in-person and virtual trainings for naloxone administration for almost 7,000 people in the city of Detroit. Training has been provided to numerous organizations, and in addition to these kits and the training, 73,000 fentanyl strips and almost 5,400 xylazine test strips were distributed last fiscal year. Additional efforts designed to address disparities slated for the coming year include adding the distribution of naloxone and fentanyl strips to community wellness centers across the state. These centers are located within our trusted partners, including churches and other well-known locations. These were what began as our neighborhood testing sites during COVID, became vaccination sites, and we've been able to transition those into community wellness centers. Pretty significant. So the settlement will continue to focus will be a continued focus, I think, of presentations to the legislature this spring, but we are continuing to work on making sure that we are putting as much information about this on our website. Additionally, we know that an important part of improving access to physical and behavioral health care is also making sure we're working together to strengthen our healthcare workforce. This is the part you've all been waiting for, I think. This is something I continue to have conversations with health systems and others about to identify solutions, and I just want to make sure that everyone understands it's also an issue that we at the state are dealing with directly as well. Our most recent budgets have included investments to strengthen our workforce, including expanding our loan repayment programs and scholarships and increasing wages for our workers. We'll continue to have conversations and work with all of our partners on this issue in the coming years, but the governor's fiscal 25 recommendation will continue this trend of investments, including a new loan repayment program for nurses specifically in return for services in state-operated and non-state operated facilities, so that we can provide loan repayment to nurses outside of just underserved areas, assistance grants to professionals to support continuing education, the American Rescue Plan funding to Michigan's public universities to continue to support expanding internships and scholarships, and continued expansions of those CCBHCs. We have an incredible opportunity right now to improve access to behavioral health care, and this will continue to be a priority. Addressing inequities and social determinants of health are critical components to improving health outcomes in Michigan. In recent fiscal years, including the current year, we've invested in the recommendations that the state's Racial Disparities Task Force aimed at reducing inequities across the state. We established and expanded Healthy Moms, Healthy Babies, our maternal and infant health program that began with Governor Whitmer's first term, to provide professional doula services for people with high-risk pregnancies, new moms, and families. We made sure that services and programs to support Medicaid eligible moms, with everything from lactation to addressing postpartum depression, continue for a full year after birth. We increased home visiting, we invested in birthing hospitals and regional collaboratives, and among other initiatives, we've also invested in a pilot program designed to address the leading causes of health disparities, such as lack of healthy foods, by concentrating our resources. The establishment of healthy zones to bring community members and resources together to address barriers like food, housing, and other environmental factors that we know contribute to health disparities. Our mobile health units that are designed to address barriers to accessing health care by meeting people where they are and offering preventive health care and, if needed, referrals to other services. And access to critical care for sickle cell disease, and targeted public education on uterine fibroids, both of which disproportionately impact Black communities. In addition, we are continuing to work on improvements to the collection of race and ethnicity data, including information that will help assess the impact of key initiatives. The fiscal year 2025 budget recommendation still includes further investments in Healthy Moms, Healthy Babies, the continued implementation of recommendations from the Racial Disparities Task Force, and in January, the department was able to host another social determinants of health summit to engage our partners. This was to talk about implementing phase 3 of our statewide strategy, which is a framework to engage the public in this collaborative, our upstream approach to removing barriers to social and economic opportunity. Attendees discussed best practices from other states and our recent work. It was, I think probably many of you were there, it was very successful. In addition to continuing these efforts, one of the main areas of focus of our Phase 3 social determinant strategy is the incorporation of health in all policies. Health in all policies are a decision-making approach that seeks to ensure all policies have neutral or beneficial impacts on social drivers of health, and it places improved health for all and the closing of health gaps as shared goals. The fiscal 25 recommendation supports our ongoing work to address social determinants of health and includes investments in the summer food program to bring home federal tax dollars and ensure that our students are getting adequate food over the summer. And the last item I want to mention briefly, and I could talk literally all day about the stuff we're doing, is another one of my priorities, which is our Keep Kids Safe agenda. People don't always think about our human services programs when they think of health. But our Keep Kids Safe action agenda includes efforts to address social determinants and drivers of health across 5 pillars. We know that if we can provide families with economic support, it's more likely that children can remain safely with their parents instead of being placed in foster care. And if foster care placement is needed, providing these economic supports can make it safe for the children to be reunified with their parents. One of the initiatives I really want to highlight today is our Family Impact Team project, or FIT. Everybody in the department really likes their acronyms, so we don't speak in words. So FIT embeds family resource specialists with the department's child protection services and foster care staff so they can support families in applying for benefits and Medicaid and connect them to other economic supports. The first phase of the program began last August in 12 counties, and in the first 2 months, the FIT team delivered services to more than 500 families. We're working on ways to continue to expand this program to other counties this year. It seems like such a simple solution, but something that we had never done before, which was to combine our economic security and our children's services staff and have them work as teams. And it has been, from our staff perspective, one of the most fulfilling things that they've ever had the chance to do in this department. So I'm really excited about it. Like any state, we have complex challenges to solve. However, what I want you to remember and leave with, we also have incredible opportunities to continue to improve the health and prosperity of Michigan families. As we continue on this path, hearing from all of you, from other people who are working directly with individuals and families every day, is so critical to the work that we are doing at the state level. I'm really excited about some of the presentations and conversations I know you're going to have today as part of this conference, and I'm sorry that I have to leave, actually. But I do appreciate your time in this morning, and I look forward to all of the questions, I think, that you're going to be asking. So thank you very much.
Thank you, Director Hertel. You covered all the questions I had. I don't know how that happened, but I do want to go back to one item that you did address, and that's workforce. And a group of us were talking last night, and obviously, depending where you're at in the health systems, what your priority problems are will differ. But the biggest consensus we had is workforce, and we all know this. We're seeing it everywhere. And I want to dig a little deeper on a couple of issues. I mean, what's really clear when you talk about workforce is cost of living, child care, but also what keeps coming up is administrative burden and efficiencies. And I think about HIPAA that was supposed to streamline all the data transfer and everything, and I don't see it. I mean, there's more data being exchanged, but we've still got systems where workers have to enter stuff in different systems, and it's all different. They aren't talking to each other the way they should. Is there a role for MDHHS in fixing that?
That's a really good question. And the answer to that is yes, sort of. We recognize the same barriers because, well, first of all, within the department itself, and you know this, we have however many, 350 different systems, and most of those don't interface with each other. So we are starting the process of trying to ensure that our systems are able to talk to each other internally. We are also recognizing that there are different groups who perhaps should have access to some of the information in the systems we have in order to achieve some of the outcomes. So one of the significant changes that we're in the process of making, I think the MOU has been signed already, and this does have to do with foster care children in our MySACWIS. We have a number of standards that we need to meet when it comes to health care for children. And all of our foster care children are enrolled in health plans, but our health plans never had access to the children's information. So we are changing that so that we can make sure that our health plans have the same information in front of them as our children's services workers. And we're also making sure that our community mental health partners have access to that information as well, so that everybody is working off of the same information and can be making decisions as a team, ideally, but with everything available to them. So we're starting, I think, to try to lead by example in that, as far as what information sharing should look like.
That would be a welcome change.
Yeah.
Very much so. You also talked about opioids, and I know that the department is funding a lot of work to increase MOUD, MAT in carceral settings. Both DOC is doing it in the prisons. There's a project right now to expand it to jails. The critical incident there, or critical need there, is the reentry and making sure we get these people connected immediately to needed services, which goes back to your whole thing of behavioral health access. How is the state addressing the need for the demands on the delivery system from reentry? Because the number of people exiting correctional settings on MAT is going to skyrocket.
So as part of the fiscal year 25 budget recommendation, you may have seen that we have asked for funding to support the corrections waiver to allow Medicaid to pay for services 30 days prior to release for adults and children. Michigan's waiver request is unique in that perspective, that we're also asking for children. So I know that the federal government, you might want to ask Michael while he's here, as a favor to me, how quickly they can maybe get some of those things approved. But we are working to aggressively find ways that the department can be supportive of the correction system and making sure that there is access and payment for services for those leaving the system.
Super. We've got about 15 minutes left, and so I do want to open it up to all of you if you have questions for Director Hertel. Don't be shy. I know you've got things you want to know. All right, well, we'll keep going then. Child welfare, you talked about the FIT teams and the Keep Kids Safe action agenda. Our welfare system, and I've heard you say this, our child welfare system is 40 years old. And so I've seen the studies that the task force work that the department has done. Where does that stand right now, other than what you've already mentioned? Is there more you can say about how we advance that?
There's so much I can say. It has been one of my top priorities. So we are still operating under the federal consent decree when it comes to child welfare. We're 15 years in on that. We spent 6 months last year renegotiating with the plaintiffs and the judge the metrics that we need to achieve in order to think about exiting this consent decree. We made significant progress in changing the metrics to things that we actually can control. When we think about children and families in the child welfare system, this is exactly the model of talking about how social determinants affect outcomes, because we need to wrap services around those families in order either to keep children safely with their parents or to be able to reunify them. So we're currently working in 6 counties right now to talk about reunification and permanency. Those 6 counties have identified the top 3 barriers to reunification. Can anyone guess what the number 1 barrier is? Like, really? Does anyone have any idea? Yell. Oh, that's number 3. Substance use disorders. Number 1 reason we remove children from their homes. Substance use disorders from their parents. Number 1 by far. So we are targeting funding. We are targeting programs. We're working with our CMH partners, working to make sure that we're able to identify programs and services quickly, and then through the incorporation of those FIT teams to make sure that we're providing services to families so that they have what they need to stay together. I've said this before, I'm sure you've all heard this, poverty is not neglect. And the child welfare system is a legacy system that equates poverty with neglect. So we need to move past our expectation of what a family life should look like and move to the reality of what is safe for a child and a family. So I have the Keep Kids Safe agenda, which continues to expand on a number of strategic initiatives. We'll be rolling that out, the broader Keep Kids Safe agenda, in the next month or so. And it really delves into changing the system itself, looking at What does our staffing model look like? What do our contracts with our providers look like? And really trying to make huge changes. I mean, there will be significant changes to that to create a child welfare system for 2024, not for 1994, which is the system that we have in place. And I can tell you, one of the things that people say, I hear often, is that the system is broken. And I'm telling you, the system is not broken. The system works exactly like it's designed to work. And that is the problem. We have to change the system. So we have a lot of work in front of us. I'm really excited about it. I'm really overwhelmed by it. But I think that as we do that, and in conjunction with the investments that we're making for behavioral health services with children, we're going to see some significant improvement in our outcomes. And I even believe that we have a path to exiting the consent decree by the end of Governor Whitmer's term. So we have a lot happening.
That's encouraging. You mentioned the social determinants, and that gets a lot of attention these days. And in the rebid, there was questions about social determinants, but it looks like the primary funding vehicle will be in lieu of services rather than an 1115 waiver, which several states have done. Can you explain why the state chose to go with an ILOS funding mechanism rather than a waiver?
Yeah, the waiver doesn't really make sense for us because we already have the managed care waiver, and we can do so much with our health plan partners through that waiver that we don't need to go through the 1115 waiver. So we are taking the in lieu of services route and working with our partners in the health plans to develop the programs and systems that they think are most beneficial. And as probably all of you know, all of our health plans have already been delving into these areas because they recognized a need. So this will offer additional financial support to those programs and then allow us to capture that data to see how those programs are working. I will say, and I've told Michael this too, I am still a little skeptical of the 1115 waiver concept on social determinants. And I am sitting back and watching the other states who have done this, North Carolina, California specifically, and to see their data. Because as the director of an integrated department, I can tell you, and you all know this, we already have a whole bunch of programs in place to address social determinants of health. So what I would love to be able to do, and something that I and some of my colleagues have talked to the federal government about, is, hey, can you help us on the human services side, where those social determinants programs are, to better align eligibility and data collection and those sorts of things, so that those programs are easier to access potentially for individuals and the funding streams, instead of trying to medicalize some social determinants. Because if we, for example, try to use Medicaid payments for food pantries, what we're talking about on an administrative level is potentially asking all of those food pantries across the state to become a Medicaid provider and then be able to bill Medicaid. That's just not feasible for so many of our community partners to be able to do. So we really are sitting back and working through the in lieu of services piece, which we're very excited about. And one item at a time, we did food security first, and waiting to hear from some of the data on some of those other programs in other states. And if I had to guess, there's probably a reason that some of that data is not coming out yet. Because it maybe was a lot more complicated or a lot more expensive than what they had anticipated. So the one positive thing about all of this is that it has everybody talking and understanding the importance of social determinants on health outcomes. And I think that we have come a really long way in recognizing that most of the things that affect your health outcomes happen outside the doctor's office.
Very true. So you noted you're starting with food insecurity.
Yeah.
Do you can you share a list of what's next?
For me, what would be next is housing. Okay. But that, we're going to work on food insecurity first. We're going to see how the governor's proposal in the budget recommendation goes. I mean, there is a clear recommendation or recognition among decision makers and our community partners that housing is a significant barrier for many, many people, not just in this state, but across the country. And the governor's budget recommendation recognizes that. I will say Director Amy Hovey from MSHDA has been a great partner to us in really trying to identify housing barriers as a social determinant of health. So I think housing probably will be the next thing we want to talk about, but we're going to want to get through the food security stuff first and see how they can make some investments in the housing stock before we move into that direction.
I'm not going to ask a question that I know you can't answer, but we're all waiting for the Heidi LTSS DSNP RFP to drop. But in thinking about that, when you look at the LTSS landscape for Medicaid in Michigan, it's pretty small. Other than just what'll happen with the duals, are there plans to expand the LTSS landscape in Medicaid in Michigan?
Not today, but there is a clear recognition on our part that the industry is getting smaller. We're seeing a lot of our adult foster care closing, and they have been a significant driver and support network for many people who are in our long-term supports and services program. So I think as we work through looking at maybe a budget for next year, I know that we're going to be talking a lot about long-term care and adult services in general. So yeah, it's a great question. I don't actually know the answer to it yet, but it is something that that has been raised to me by a lot of our staff, actually, and not my Medicaid staff. A lot of my county office adult services staff who are very concerned about what's going to happen to their clients.
Every year it means more to me. I never thought I'd care about that, but I do now. I still want to encourage questions from the audience.
Thank you for all you do. More of a comment than a question. Mark Meyer from Life EMS Ambulance in West Michigan. Just wanted to give you feedback on the positive impact that the grants and scholarships for workforce training have done in the emergency medical service world. We recognized through the pandemic that we had to bolster our internal training and our internal talent pipeline, and the scholarship stuff really helped kind of come in behind that and help us with some of those increased costs. But we're trying to flood the zone with EMTs and paramedics, and that's really been effective. So thank your folks in the EMS division at MDHHS. They've really done a great job with that. So thank you.
Well, thank you for that. I will let them know because people are usually yelling at them, and they will appreciate the positive comment. Thank you.
Good morning. Christine Van Landingham, CEO at Region 4 Area Agency on Aging in Southwest Michigan and president of the Association of AAAs in Michigan. And to your point, yes, I know you can't speak to the DSNP RFP, the Heidi DSNP, but I do appreciate some of your comments and I welcome your thoughts on aligning systems and building on existing infrastructure versus duplicating, reinventing, et cetera. So we've done in Southwest Michigan some really cool proof of concept when you bring together community-based expertise in care management, really that blending and braiding of those social infrastructures that you mentioned, and really when we bring those social care clinicians in with medical care teams and marry the payer with that, and we have some proof of concept that when we address social determinants of health from that perspective, from that boots on the ground in the home, perspective with care managers who really know the community, know those food pantries, know those loan closets, and really get Medicaid as a payer of last resort, but really taking a person-centered approach to what's important to the person, not what we as clinicians think is important for the person. And what we've been able to do with this proof of concept is for those older adults with multiple chronic conditions, so those folks who many of them will be dual eligible for the DSNP, HIDE DSNP, is be able to greater than 50% reduce unplanned inpatient hospital stays, ED utilization, length of stay, and candidly it was a 100% reduction in ED to SNF placement. So most importantly, that's a great member in person experience, but it was an opportunity to bring together and blend and braid those systems, and you can do that on a local level with the kind of partnerships and relationships that we have. But we need some structural opportunities and some leadership at the state to help us take this proof of concept and really deliver that for the entire older population. So I'd welcome your thoughts on that. What are the barriers to that as you see? In lieu of services is one mechanism, but there's so much more to that I'd love to see us really dive into what we've been able to do and how we can move that forward.
That sounds amazing. A couple thoughts on that. One, I love hearing person-centered. We've used that term for a really long time, person-centered planning, person-centered, without really realizing that being person-centered is really what is going to reduce the inequities that we have in outcomes across the state. So fundamentally recognizing that we have to ask people what they need instead of guessing or telling them what they need is important. And once we're able to do that, we can wrap services around them to support what they need and what they want. We have to do that at the local level. I know the things that I know from a statewide perspective. So what I'm always asking people for is to tell me what is working at the local level. I don't know because I don't operate at that level. So the more that we can learn from what you're doing, the more we can think about how we incorporate that into our broader statewide policies and provide you the supports and resources that you would need locally to continue to improve those types of services. So I don't know what I don't know, and it's a lot. Believe it or not. I mean, people assume I know a lot. I don't know anything, really. But you all know a lot of stuff, and I rely on you to tell me those things so that we can create a system of resources to support all of those great things that I know you're out there doing.
Thank you. And I've got a red light flashing at me here, so I think it's time for us to move to our breakout sessions. Thank you again, Director Hertel. We appreciate you being here and sharing your insights with us today. Breakouts are down the hall, and they start at 9:30. Thank you all very much.
Thank you.